button for his system.
Yeah,
No, I didn't. I'm not. You're gonna record it and send me the recording so I put it on my website. I'm not recording. No, I'm using my iPhone because my iPhone. I'm writing the book on the iPhone, not the computer. The reason why, because it's a lot of work. You know, it may take. It will hurt my back if I'm sitting on the table. So I have to, yes, just use the phone while I'm lying with watching TV or doing something at the same time as the AI, and then they send me information, and then I have to go and say, oh, this is not good. I need more here, more there. And so I ask him different questions, or I start refining the question. So can you see me? Can you see my, is this
you are
is it
sharing
shared?
screen, it says. Yeah.
Okay, you can see my shared?
Yeah.
It's pretty much shared. Okay. So this is the book. Okay. Let's start from, so it's 100 and it's, if you see here, it's 302 pages, right? You see that the pages numbers? It's 96,000 words. And so this is the beginning of it. I don't know we're starting or not, but I think we're not still. I'm going to show you your part. Okay, so let's go.
We got one more minute, and then it's 5 o'clock here. So.
Yeah, but I think we need to wait for the people to attend. What's me and you? Let's just show you exactly where metabolic syndrome is.
Does anybody else have Dr. Clearfield or now my picture? It's like it's in the middle of the display, the middle of your book.
Can you see? Oh yeah, I know. I'll put it down here.
Got it.
Yeah. Let me see. So this is the metabolic syndrome. Okay, so this is the beginning of it. Improving metabolic health, metabolic dysregulation. So this is the topic of estrogen dominant here. Now make sure that's the case here. AC inhibitor, pharmacoprevention, and I'll make it bigger. Metabolic syndrome. Okay, no, that's still the front. Yeah, the big one. This physiology. Let's go and see here. This is chapter 3. Okay. Okay, so let's go with the mobile size. So now it's bigger, right?
Yeah.
You see it clear? Okay. So this is the chapter 3. So I'm talking about obesity here, and you know, it's based on the BMI plus the visceral fat, the circumference of the abdomen. That's very important. And then the epidemiology of this, and of course the association of the condition that associate with obesity, etiology, and then all this causes of obesity, of course, lifestyle, environmental, epigenetics, genetics, and all that. And then the pathophysiology here, you know, it's obesity. Part of it is inflammation, and the fat get resistant to respond to the hormones that breaks down the fat. And so it's at oxidative stress. Along with that, it's endoplasmic reticulum stress, which is all it's under the endoplasmic reticulum. It's under oxidative stress. It's under, when oxidative stress, part of it is mitochondrial dysfunction, right? Because that would generate free radicals. So anyway, this is the etiology here and of the obesity. And then if you go the way the management, of course, you know, it's all about lifestyle change and some pharmacology.
Why don't we start by it's a little after 5, so let me introduce you, and you can start from the beginning.
Right, but I mean, me and you, but still not yet, right? We're not yet there.
No.
Oh, you want to start now?
Yeah, it's after 5. We have a little bit of a crowd, so.
Okay. You want to do it? That's fine.
Yeah. So welcome everybody, and hope you all had a good holiday season, however you spent it. We have a bright new year. This will probably be our last webinar on Zoom. We were probably be able to make the transition to A4M this week, but again, with the holiday and whatnot, I didn't want to make sure, because there may be glitches, or no, it should work pretty smoothly. Just pay attention for next week's email. The link will be different. and we become part of the A4M family. It's also they're going to be advertising it for us, so we're pretty excited about that. So for tonight, we have Dr. Halasa, who needs no introduction to our group, and he has finally buckled down and began putting together the Bible for chronic disease management. And I thought it might be a good idea to have him on and have him explain, what he's doing, what it's going to look like, what chronic disease prevention management entails, if you're not sure, and if he needs any other collaboration, we have some pretty good minds here. So Dr. Halasa, take it away.
Yeah, thank you for having me in your show, in your conference. Yes, I think we need to structure structure this field of medicine, which is chronic disease prevention and management. And I think it include all the other titles that we are using: integrative, holistic, regenerative. All of this are under the big umbrella, which is chronic disease prevention and management. Because the purpose of this alternative medicine that we are doing is to manage chronic disease and preventing them. And the American Medical Association recognized this term, CDPM, or chronic disease prevention and management. They really don't yet, the mainstream medicine, recognize integrative, regenerative, holistic for some reason. But they like the name of CDPM, which is based on that, addressing the pathophysiology or addressing the diseases that you are managing. So we are managing and preventing chronic diseases. And I think the best way of doing that is to combine integrative and mainstream medicine. And that's what we do in CDPM. We combine the mainstream protocols that make sense, that is for the best interest of the patient, not for the best interest of the big pharma. And also what is reasonable in integrative, holistic, complementary medicine, because I can see that this field of medicine it's like politics. It's like Democratic and Republicans. They're going to the extremes. I think we need to come up in the middle that serve the patient, that serve the outcome of the patient, does not serve filling up the pockets of the big pharma, or the extremes of integrative, regenerative, where they don't recognize anything in what they study in the medical school and what makes sense. So we need to combine both of those protocols in a way that is less toxic. And even if they're mainstream medicine protocol, they have side effects, how we can minimize those side effects using supplement or using integrative protocols. So we can do that. There's a lot of way that we can reduce the side effects of statin, for example, by making sure the patient is taking extra QQ10, or if they're taking metformin and metformin causes malabsorption of vitamin B12, then we need to give them B12. And so this kind of combination of these two approach, integrative and mainstream medicine, is part, or it's one of the blueprint of the book. The other blueprint of the book is that we approach chronic diseases based on those four pillars, which is modulating and restoring the regenerative status, the metabolic status, the immune status, and the redox status. Those are the four pillars that when we trying to manage any chronic disease, we have to look at those four things. The metabolic is not just it's not just the sugar and the lipid and the obesity and hypertension, which we define that as metabolic syndrome. But metabolic means all the metabolic pathways. You're gonna screen anything that causes imbalance, impairment in the metabolic pathway. And that includes sex hormones, vitamin deficiency, nutritional deficiency, anything that endogenously deficiency, those chemical endogenous in the body that's produced in the body, there's any deficient needs to be screened out and needs to be we need to supply it or replenish those deficiencies so we can optimize the metabolism in the body. So if you have vitamin D deficiency, give them vitamin D. If you have imbalance in sex hormone, deficiency in testosterone or progesterone or estrogen, all of this needs to be optimized, right? And also we looked at the chronic disease, the redox part of it, which is looking for all those free radical generators, whether those free radical generators are toxins, environmental toxins, whether it is a problem with metabolism and generating free radicals, they have deficiency in or genetic or epigenetics and their antioxidant machines, and they are generating free radicals. They are unable to clear or clean the byproducts of metabolites, and those byproducts are free radical generators. So all of this needs to be screened out. And if patient has fungus infection, environmental toxins, taking medication is inducing oxidative stress, or you have leaky gut, or you have underlying inflammatory condition, you have diabetic hypertension, all of those can be source of free radicals. And so we need to screen them and manage them, right? And then the third part is looking at the immune balance, seeing where the immune is. I mean, what is the status of the immune? If there's hyperpolarization to Th1, Th17, or if you have cancer, you have too much of Tregs protecting the cancer, then we need to modulate the immune system and balancing and shifting the immune system in a way it will be balanced and optimized to fight cancer or infection, or to balance the immune system so you can manage allergy and autoimmune disease. So a lot of condition like rheumatoid arthritis, you'll see you have too much of Th17 and Th1. So how you can polarize it back into Treg and Th2. So there's a lot of interventions that we can do to balance the immune system, but we need to screen that first. We need to do that by checking the lymphocyte profile and cytokine level, or cytokine and lymphocyte mapping. So those are the three. And then fourth, the regenerative status. And basically, after you fix the metabolic redox and immune, then you're ready to start giving exosomes and stem cells to help to regenerate and help to normalize the redox and metabolic and immune at the same time, because those stem cells do have all the ingredients that helps to normalize the other parameters. And if you see those four things, those four parameters, they really overlap. Sometimes when you fix vitamin D, it does help to empower your antioxidants and balance the redox, but at the same time, it balances your metabolic. And if you balance the redox and metabolic, then you are improving the status of your regenerative status. And so they are all connected with each other. Same thing like sex hormone. Sex hormone doesn't have the Th17, and sex hormone does stimulate the expression of antioxidants. So you can see that balancing one system or one part of the pillars of those key processes of our body, if we balance it, it will definitely balance the other. So they are overlap. And so based on this concept, based on this blueprint, definitely I come up with this book, first explaining those four things with chapters. So we have the metabolic chapter, we have the redox chapter, and then we have the immune chapter, and we have the regenerative chapter. And that's where you will see in this chapter 2, redox state and role in health and disease, and then chapter 3, metabolic pathways. Again, metabolic pathways, not just sugar and fat and obesity and hypertension, which we say that which we label this as a metabolic syndrome. No, it includes all the metabolic pathways in your body. It needs to be optimized. So if you have deficiency of sex hormone, growth hormone, peptides, anything that's endogenous, and you are screening it and there's deficiency there and you replenish it, that's part of the metabolic. And nutrition deficiency, vitamin. And then the redox is, yes, it's all sorts of the free radicals. Those free radicals could be leaky gut, is releasing free radical, could be toxin, could be fungus, could be infection, could be underlying chronic disease, could be some errors in epigenetics where they are not expressing enough of antioxidant, like in Parkinson's disease, they have problems in cleaning up the waste, and the antioxidants is compromised epigenetically, and so they have problem with the clearing the quinins. That's the byproducts of L-DOPA, and the quinins is actually inducing apoptosis and degeneration of the dopaminergic neurons. So we talk about those 4 chapters, and then we also talk about how the body as a whole is all connected with each other. So if you have diabetic, which means that you have too much of sugar in the blood, means that those sugar will get oxidized and they become free radical generators. Then those free radical generators will mess up with other systems, right? It will lead to neuropathy. It will lead to angiopathy. So it will affect other systems. So diabetic is not just an endocrine disease. It leads to a neurological condition. It leads to kidney problems. And so if you see that that the body is all connected, and so you cannot just say, I'm gonna fix diabetic by endocrinologist and he's gonna take care of it by just giving me or give the patient insulin. No, you really need to see all the complication which involve other systems of the body. And so it's all interconnected. Or if the patient has diabetic, at the same time they have rheumatoid arthritis, well, those free radicals that's coming from the inflammation from the rheumatoid arthritis, it will aggravate the condition of the diabetic, because those free radicals will cause insulin resistance, right? And then the patient needs more insulin. So managing rheumatoid arthritis is part of managing diabetes. So if you see here, all the systems of the body are all connected. So if in order to manage it, especially with diseases that's multisystemic, then you need to have understanding of all the systems of the body, not just tunnel vision that we see in as a medical specialist. They become so tunnel vision that the patients are not getting the best outcome from their management. And then you see all this conflict of the treatment from all different medical specialties, and they don't see the body as one. They see it as systemic. And once we get to that point, then we will, the patient's outcome and the health will not be as optimized as if we manage and be trained to manage the patient as a whole body. So that will be a chapter that will explain the interplay of systems in chronic diseases. And yes, and then of course I'm expanding this book so it will become a textbook. So there will be chapter for each system. So there will be chapter for chronic neurological diseases, chapter for chronic musculoskeletal diseases, and the common ones among those conditions in its system, and then how we manage them how we manage them based on those 4 pillars, based on regenerative, immune, redox, and metabolic. And so it's revisiting the whole medicine, redefining medicine, and looking at it from all different angle. And that's the book. And so if you go and we see chapter 1 here, I'm just going to put in the mood so you can see it. So in chapter 1, it just explained the chronic diseases and how it has impact on the health of the whole globe. I think 60 or 70% of adult population are suffering from chronic diseases, and this chronic disease prevention management specialist, it is unmet medical need because the specialists did fail to manage multisystemic disease. You really need to have to be trained to manage diseases or conditions or chronic disease as a multisystemic versus one system. I mean, in acute conditions, we did very good with mainstream medicine protocol. When it comes chronic, and you start focusing on one system, you lose all the control of the condition itself, optimizing the condition itself, because it involves optimizing other systems of the body in order to manage that specific diseases, because it's influenced by the conditions of other systems. And so We're making sure that CDPM, chronic disease prevention management, yes, it lines up with the CDC guidelines. And so we are on the same page here. It's being promoted by American Medical Association. What they did, American Medical Association, they redefined the way we take history and exam to be more comprehensive, to include every aspect that leads to stress in the body that aggravate the inflammation of the body. And that include all the social stresses, work stresses, family stresses. All this history needs to be more inclusive and involve all the biosocial environment of the patient. Because, as I said, you can have psychosomatic effect on the condition. If you do have stresses from outside, whether it's from work or from family or from the finance, or all those stresses can cause psychosomatic effect, which can cause overactive or sympathetic. And when you overactive your sympathetic, what will happen? You release those norepinephrines, and norepinephrines are pro-oxidants. They will stimulate NOx enzyme and generate free radicals and aggravate any critical condition that you have. And it will also stimulate the release of extra cortisones, and then this cortisone will suppress your immune system, and especially the Th1 polarization, and move the immune system more into Th2 and Treg, which will put the patient at risk of infection and cancer. That's why we see that stress, even psychological stress, can be a risk factor for cancer and for infection, because it suppresses the immune system, especially the Th1. The cortisone suppress Th1 even more than Th2 and Treg. So you can see that moving to that direction, and put the patient at risk. So because of that, all the stressors, whether it is social and psychological stressors, they need to be included in the history and exam. Because if you don't eliminate those stressors, those social stressors or psychological stressors, then even if you manage the patient and giving them everything there that we have to optimize the health and trying to normalize the parameters of the body, it's still not going to work if the patient still is being stressed because of the overactive sympathetic and the cortisones, which will definitely return the patient to ground zero again, or suppress the immune system, put them at risk of infection and cancer. So that's what the AMA, American Medical Association, is emphasizing on this social bio stressors and include them in the history. So they come up with something is called 360 HP, which is history and physical exam, to be more comprehensive, including all the systems of the body. So when you examine a patient and you are a neurologist, it's not just enough to examine the nervous system. You need to really examine all other systems of the body, because if you have a condition that's affecting the nervous system and you have a neurological disease like Alzheimer, right? Well, if you have diabetic, if you have rheumatoid arthritis, if you have any of those other conditions, if you have fungus infection, if you have leaky gut, if you have toxin, if you have 6 hormone deficiency, all of this can definitely aggravate the progression of Alzheimer's disease. So in order to manage Alzheimer's, it's not just enough as what we're doing in mainstream medicine. Oh, what we have the problem of deficiency of neurotransmitter acetylcholine. Okay, let's go ahead and inhibit acetylcholinesterase, increase acetylcholine bioavailability, and that's it. That's the treatment, right? That's the mainstream medicine. That's called neurologist. No. Well, what causes the progression of this degeneration of those neurons? It's the free radicals. Okay, where they come, those free radicals? It could coming from the leaky gut, could be fungus infection and bacterial infection, could be from 6 hormones. It could be from the medication patient is taking, narcotics. They can induce oxidative stress and cause more degeneration of those neurons in your body. And so you need to screen all that. Could be from alcohol, could be from social stress, from his work, right? All of this could be a factor in aggravating the progress of the disease. So what I'm looking now, I'm screening all the free radical generators, right? And then I'm also looking for any metabolic deficiency. Oh, it could be the aggravation because of vitamin D deficiency, because vitamin D empowered the expression of antioxidants, which is very important to alleviate the the free radicals so you can stop the progression or slow the progression of Alzheimer's disease. And so metabolic redox, what about the immune balance? Yeah, because of this oxidative stress, you would have the gliosis, inflammation of the glia, you have more of Th1, overactive Th17. Can we modulate that without suppressing the immune system? Yeah, you can. Dr. William likes to give low-dose naltrexone, helps to polarize or balance the immune system, shifting the immune system from Th1, Th17 to Treg. And that helps the patient with Alzheimer's, or patients giving them peptides. There's a lot of peptides that modulate, not suppressing, modulate, just shifting it. There are too much of Th1, Th17. I don't want cortisone to suppress the whole thing, right? Putting the patient at risk of cancer. I just want to have something that inhibits only Th17 and Th1 and move it and balancing the immune system, right? That's called immune modulation versus immune suppression. And so we have a lot of things that we can do. So we can restore the immune, the metabolic, the redox, and also after we finish all of this, then we say, okay, we clean the weeds, and now it's a time to seed the plants, and we can give them exosomes or stem cells to help to rejuvenate the whole tissue there. But after we definitely clear the weeds and we restore the redox, the metabolic, and the immune. So that is that's the whole purpose of chronic disease prevention and management. I think this will provide the structure that we need for so that we can have this field of medicine recognized by the mainstream medicine. Now we have solid protocols. We're not shooting in the dark. Everything that we are adding there, it has a reason why we either classify it as are we balancing the redox or immune or metabolic. So we have the mechanism of action very clear. We're not saying, oh, it works, but I don't know how it works. No, that's not the mainstream medicine, and people are controlling the system here. They are PhD people. They don't take that it works, but you don't know how it works. They like the mechanism of action. That's very important, right? If in the beginning, when COVID hits, and we say ivermectin, it's inhibit the Th17, and COVID-19 is a disease that causes hyperpolarization to Th17, and we show all the mechanisms are showing that, hey, and the spike protein, blocks the ACE2, and ACE2, when you block it, ACE2, it's part of renin-angiotensin system, and if you block the ACE2, you block the antioxidant arm of the renin-angiotensin system, you allow the angiotensin type 1, angiotensin 2 type 1 to be overactive, and angiotensin type 1, when it's being overactive, the down signaling, it leads to polarization of immune system to Th17 and Th2. Away from Th1. And so then what would happen if you don't have much of Th1, you compromise the immune system to clear the body from the intracellular virus, which is the COVID virus. All right. And so what we need now to manage corona, we need to inhibit the Th17 polarization. Ivermectin inhibit the Th17 polarization. Matlambu inhibit the hydroxychloroquine inhibit the Th17. If we approach this way, or approach this mechanism of action, and we communicate with the mainstream medicine with mechanism of action, and not just ivermectin works because it works, and we have clinical data from China or from India, from Pakistan, where the mainstream medicine does not, they don't recognize their studies, then I think we can have better shot with the mainstream medicine. Those PhD and those people are controlling the system, but I don't think that's the way that we. I don't think that's the way that we communicate with mainstream medicine, and then all this mainstream medicine, docs, they say, they start criticizing us, not knowing why ivermectin works, how it works. It's a parasite drug. No, it's not parasite only drug. Yes, it does inhibit the parasites, but also it's anti-inflammatory. It does inhibit the Th17. That's why it's FDA approved for rosacea. Why? Beside it kills the mites. It also inhibits the Th17. And we know the pathophysiology of rosacea is overactive Th17. The same thing with COVID. It's an overactive Th17 immune. So if we communicate with this way, with the structure, with understanding the mechanism of action of how things work, I think we can have better shot in getting the mainstream medicine aligned with us and understanding us, instead of having this conflict, the big conflict of the century between the two doctors or two studies, the mainstream medicine, integrative. So the integrative, they need to reason what they are. They need to reason their protocols. They need to structure. And integrative medicine, holistic, regenerative, it's like a wild horse. There is no structure there. And the mainstream medicine is laughing at us. And of course, being supported by big pharma. So you don't have any structure, you don't have any protocol, you don't know how it works. And if you don't know how it works, you cannot create protocols. Because if you try to put two things together and you don't know those two things, they may conflict each other, right? If it's not conflicting by the mechanism of action, they may conflict in the metabolism. Example, one of the doctor from Libya, he just reached out to me and he say, my mom, she has an asthma. He's a president of Kabal Hospital, one of the rural area, I mean, in Tripoli. And he say, his grandma, yeah, she has Alzheimer, no, she has epilepsy, and also she has asthma, and they prescribing him phenytoin and beta blocker. Is any conflict between these two drugs? Mechanism, there is no. That's bronchodilator, and the other one is just more or less of inhibiting pustulgium or calcium channels. So there's no much of there in the mechanism, conflict mechanism. But when it comes into metabolism, yes, one is activating the metabolism of the others through may possibly the P50 450 of the liver. And so if you give phenytoin, then you will have degrading the beta blocker, so the patient end up with asthma. Or you give the beta blocker, it decreases the bioavailability of phenytoins, and then patients have epilepsy. So it needs to be adjusted. So you cannot put protocols and you don't understand the mechanism of action of the drugs or supplement that you're putting. That is where chronic disease prevention management, we emphasize on mechanism of action first. If you don't know how it works, even if it works, it could be placebo effect, right? Do you know the placebo effect? If I tell the patient, this is going to help you, right? And this is going to improve your neuropathy, and you're going to feel better. You're going to sleep at night better than before. You have less numbness. Do you know what happened? Just by saying the good words about this thing, even if it's water, right? It's nothing. It's normal saline, right? And you start saying good words about it. In other words, giving them all the good effect, and you explain to the patient this is going to happen, it's going to improve, and all that. And the patient believes in it. What will happen because of expectation that he's going to be improved and he's going to feel good? Oxytocin kicks in, and oxytocin itself will cause or will help in the healing itself. And it's because of the oxytocin is causing the placebo effect. So it's real. It's not a gimmick. There is changes in his body because of all the good words about this product. Made oxytocin to go up, and then the oxytocin will help in healing and resetting and the pathophysiology and restoring the balance and the redox and the immune and regenerative, everything. Oxytocin, actually, it's a drug that will restore your, not 100%, but to a certain degree, your immune, redox, regenerative, and metabolic. Okay, that's why I'm a for oxytocin. That's why when you are happy and excited, even if you have arthritis, you will start, the pain is not as much. And I think there's a video there on YouTube by watching an old guy with a can, right? And he's hardly can move. And then when they play the music and you see everybody is dancing, and he start feeling the dance, and he start moving with with the music, the oxytocin is kicking, and you can see the guy that if he's throwing his can, he start dancing like he has no arthritis. And the reason, because of that happiness and excited, increased oxytocin, and oxytocin decreased inflammation and give him that analgesia effect and euphoria effect, where he doesn't feel the pain anymore, and he start dancing like normal. And so this is very important, that understanding the mechanism of action for for us as chronic disease prevention physician doctors is very critical and it's very important. Now, I would like to go through metabolic syndrome and obesity and estrogen dominance. I don't know if you hear me, guys, because I don't see myself in the screen. Can you hear me?
Yes, we sure can.
We're good? Okay.
Yep.
So how many people attending now? I don't know.
37.
37. That's a good number. Okay. So hopefully everybody's happy here. Because I don't see myself, I don't see the reactions from you. And me and Dr. Williams, we are open for people to interrupt. Like, I have no problem for people to criticize, interrupt, come up with questions. I'm not that person who likes to be one-way teaching. So if you have any point, if you're not following up, you can stop me at any time and say, hey, this is not right. This is what we think and all that. So we get all the feedbacks, and that helps to verify the information that we're giving. So me and Dr. William, our conference is a little bit different from other conferences where it's one way, the highway, and don't interrupt me, and learn. No, we want to learn from each other here. So if I said anything that doesn't make any sense, I want you to come to the mic and say, this does not make sense. And I think this is what I believe. And I don't have any problem. We have 3 hours, right? And we're trying to turn those platforms.
Well, we don't have quite that much time, but
into discussion and debate. This is what I'm doing in my meeting. I don't know if Dr. William, I'm crossing the thing, but I enjoy the debate versus one way.
But what are the different ways you assess for reactive stress? I mean, oxidative stress.
Yes. What is that? Sorry, what you just said?
What are the different ways that you assess for oxidative stress?
There's many ways of oxidative stress that you can do. Oxidative stress can lead to clinical inflammations, and we can use all the parameters of inflammation as a reflection of oxidative stress, because oxidative stress, if it's too much, it can manifest into clinical inflammation. So all the biomarkers of inflammation can be screening inflammation plus oxidative stress. But then there's something called subclinical inflammation, where there is inflammation, but it's not manifested in the biomarkers. So if you go to the ESR, sedimentation rate, all normal, right? So it's not, that oxidative stress is not manifested into inflammation yet. So it's subclinical, it's subclinical inflammation. Then you go and you check. There's many ways of doing it. There's a lot of tests that you can check the oxidative chemicals that's coming up from the urine, and there is tests for that. You can go ahead and measure the oxidized LDL. That's one. You can but the best to measure the status of oxidative stress is to measure the functional, not the chemicals that change there, but the functional effect of the oxidative stress, which is endothelial dysfunction, autonomic nervous system imbalance, right? And in case you're doing neuropathy, it's going to be pseudomotor. And there's a system out there, they're selling it, but the people or company are selling it, they don't really know the value of what they're selling. But the heart variability in form of autonomic nervous system testing, when you have too much of oxidative stress, your sympathetic will become overactive. And that sympathetic is causing vicious circle of increasing the free radicals, and then you have that cycle. So autonomic nervous system testing, which is heart rate variability, is one way to measure the subclinical inflammation or oxidative stress that's not manifested into inflammation. Did I answer your question? Did I answer your question? No?
Yes, to a large extent, yes.
Okay, but we can go. There's a chapter in the book.
There are some specific ways, yes, but that's definitely in a large part you answer it.
Yeah, because there's a chapter for this, we're going to talk about details, because there is a lot of company are producing a way to measure the oxidative stress, which are chemicals in the body that's being oxidized in their high level, and that's a reflection of their underlying oxidative stress. So there's a lot of biomarkers for oxidative stress. There's biomarkers for inflammation. And then there's the functional testing of oxidative stress, which is the effect and the impact of oxidative stress on the physiology of the body, endothelial function, ANS, pseudomotor. And I like the functional more than chemical, because even if the chemical is normalized and all the parameters, but you still have problem with autonomic nervous system, so that's mean there's still some sort of free radicals that disturbing the physiology of the body. And so the only way I'll feel peace of mind that all my treatment that I'm recommending, whether it's all the complementary integrative health optimization treatments, is to see the endothelial function test. If your blood vessels are compliant, flexible, that's mean you are able to manage the source of the free radicals. But if it's still rigid and it's not pliable, the endothelial function is shown abnormal, then there is some other source of free radicals that's not being managed. It's like a tire with many holes, and you fix 1, 2, 3, but still there's another leakage, and you need to go back and try to screen where is that leakage causing that endothelial function. And once the endothelial function is improved, then yes, I think I patch all the sources of the free radicals generators. But that will be one of the chapters we talked about, how to monitor the efficacy of your treatments, and we're going to have a chapter for that. So I have a very big chapter for redox medicine in the book, and it's very important, redox medicine, because in medical school we did not study redox medicine. Redox medicine, a field of medicine that is now the PhDs, they have an academy for it. It's called Redox Medicine Academy or Society of Redox Biology. But there's not much clinician there to translate it into medicine. We as a group of CDPM, we're going to translate the great work that the PhD had done with redox medicine into clinical word, and explain all the mechanism of action of all those treatments, which the mainstream medicine they consider as snake oil, like photomedicine, shock wave, all this energy form of treatment that you see in A4M. All those treatments, they are considered as snake oil by the mainstream medicine because they don't understand the redox medicine. They don't understand that our body can absorb those energy, electrotherapy, sono, shock wave, light therapy, cryotherapy, hydrogen therapy, ozone, and change the biology by the redox. A redox, it's like in the computer, when you're trying to reprogram the computer, there is something is called DOS. Remember the DOS where you punch those numbers, the black screen? What switch on and off the enzyme is the redox potential. And so the concept of redox potential, hydrogen versus hydrogen potential, all of this needs to be, as doctors, we need to learn it. So once we learn it, then we can create protocols and combine light therapy with shock wave, with sono, with antioxidant, with mainstream drugs, and can see that they have synergy there, and we can create protocols. So there's a big chapter for redox medicine. I think it's going to be 50 pages or less. I'm not sure. The book is still in the stage of evolving and editing and changing. And yes, I'm using the AI to assist me so that we can have the book in a state of 5 years, printing and editing and hiring people. Then the AI is doing all the editing for me and language and helping me to extract information. And there's a lot of you need to. The AI has a language, artificial intelligence, and not just you need to speak their language, but also the AI does learn from you. So it's the AI, it's artificial intelligence. They have the storage of the information, all the information that you see in the internet. That's their storage of the information, okay? Which means all the brains in the whole world, they have it in the AI. So AI, it's the brain of the 6 billion people, maybe 7 billion people. Okay, think about the brain of 7 billion. It's in the AI. And then AI, they can process information like you are processing the information. Okay. And not just that, the AI can learn as well. And I think there is a good program there. I saw it on YouTube where they have 2 robots playing soccer, and they're programmed to play soccer, but they give them the information enough to start. But then in the process of playing, they're learning new techniques, and they are processing those new techniques and adding it as information. So the information that we start with is not as the information after maybe 1 week or 1 month of those robots playing together. There are more information being built by themselves, and being added and being stored. It's the same like humans. We we have the storage of information as as the circuits of neurons, synapses of circuits of neurons, and then we are able to, because of neurons, we call it neuroplasticity, create new ones, right? And develop new circuits of neurons in the form of storage of information. And so we can create new circuits, new connections, and store those information, those new circuits. The AI can do that at the same way, in an electric way. Of course, they have their own circuits, electrical circuits versus biological circuits. But it's the silicon creature versus the carbon creature. And I think Elon Musk did predict that the silicon creature, they may replace us, right? So the reality is that there's a lot of people chanting that word of replacing us. I'm not afraid of human replacing a human. What I'm afraid is that silicon creatures will replace us, and maybe in the future, the humans will come up chanting, the silicon will not replace us. Anyway, I'm just trying to entertain here. So in order to one of the chapter that I was talking or focusing on, chapter 3, about metabolic. Yes, it's not just fixing the fat and the sugar and obesity and hypertension, which is metabolic syndrome, but metabolic optimization of metabolism. It includes everything. It includes your sex hormone, your growth hormones, your vitamins, your nutrition, anything that endogenous, your neurotransmitters, anything that there's deficiency in the endogenous, or there's overproduction of the endogenous thyroxine, that needs to be balanced. It's part of the metabolic optimizing or restoring or modulating the metabolism. And but in the chapter we talked in detail about metabolic syndrome, but I just want to make sure that metabolic restoring and modulating metabolic is not restricted to metabolic syndrome. And yes, and we talked about obesity and metabolic syndrome and estrogen dominance. Now, obesity is basically extra fat, right? And extra weight. That's obesity. Above anybody has above 25 BMI, that's obese. So that's obesity, right? And yes, then if you are obese, then you will have risk, not necessary, but you may have risk of developing metabolic syndrome. You develop hypertension, diabetes, hyperlipidemia, right? If you are obese, then, so you can see the obesity and metabolic syndrome, they overlap with each other. And so when a patient is obese, let's go ahead and screen him if he has metabolic syndrome, right? That's what we do. Okay, and so we're going to see all the complications, and we're going to reason why. Because if he has extra fat, what's that mean after having extra fat? The fat itself, it's a free radical generators. Extra fat, edible cells, and fat tissue, they produce cytokines, and they produce inflammatory cytokines, especially interleukin-17, interleukin-6. And that leads to expression of the pro-oxidants. So they have too much of free radicals, which leads to insulin resistance, which leads to endothelial dysfunction. And when you have insulin resistance, then you have hypertension, diabetes. If you have endothelial dysfunction, then that will lead to hypertension. And then too much of fat, of course, and obesity means that you have problem with your lipid metabolism, and possibly you will have hyperlipidemia. So this is the complication, but we understand from obesity, it can lead to metabolic syndrome, and we understand the mechanism there. The fat, extra fat tissue is a source of free radical. So that's me. If that's the case, then if I'm trying to manage any condition, let's say I'm trying to manage Alzheimer, I'm trying to manage autoimmune disease, it is critical and important that we take care of the weight, the extra fat, because that is a source of free radical, can disturb your metabolic pathways and your redox, and it can aggravate any condition, underlying conditions. And if you're obese and you have all this inflammatory cytokines coming on the fat, then your rheumatoid arthritis, your joint will get inflamed more. And so it's not just enough to give them anti-inflammatory and trying to reduce the inflammation of that joint, but it's very important to go and screen the source of the free radical, which is this extra fat, and get rid from it by using the metabolic treatments that we are talking about, which activating the AMPK, right? That's what we do. And also we create a very nice capsule that is alternative to Ozempic. We know Ozempic, how it works, it stimulates the release of insulin from the pancreas, and I think it inhibits the glucagon from the pancreas. So it's putting too much stress on the pancreas. And doing that, you increase insulin sensitivity, and when you do that, then you increase the burning of the fat by increasing the insulin sensitivity there, by Ozempic, or by increasing the insulin itself. But is that good or not? Yeah, so you decrease the weight, that's good. But there's two problems here. If you decrease the weight suddenly, I mean, in a short period of time, like 30 pounds out during 1 month, people, they think it's good. No, it's not. Weight is better if you reduce it slowly. But if you reduce it fast, then you need to make sure that you're detoxing the body at the same time. Because once you shrink the fat, what would happen? All those toxins, those organophosphorus, those fat-soluble toxins that's being stored in the fat is being released out because of shrinking the fat. Those toxins will concentrate and can cause shunting in your kidneys and heart problems and cardiovascular, and you will end up with a lot of mess. So if you do weight loss, then just make sure that you detox the body with Ozempic. And also the problem with Ozempic is putting pressure too much on the beta islet of Langerhans. Then it causes oxidative stress in those cells. And if the patient has any genetic tendency to have diabetes, there's a tendency those beta cells will genetically they degenerate, or they have autoimmune or whatever. They have risk of degeneration or autoimmune destruction of this pancreas. And you're putting pressure with your Ozempic, then you're putting the patient at risk of developing full-blown diabetic mellitus. And then you end up with all the suing from all this different agency. And right now, there's a lot of cases of side effects of Ozempic, especially with damaging the islets of pancreas and developing full-blown diabetes mellitus because of that. So what we need to do to solve this problem, I'm sharing the problem, but at the same time, we need to figure out how we can solve the problem. Can we say, oh, no more Ozempic because of the side effects? No, that's not practical. Although there's alternative that we can do, we're going to talk about it. But what we need is to look at, okay, let's find out who is the patient at risk. We need to find out who is the patient at risk of developing pancreatitis from Ozempic. And so there is testing epigenetically that can be tested. And that's why I'm trying to reach out to help me, Dr. Klatz and the A4M people, to find me those companies with pharmacogenetics, to tell me which, to screen out the patients pharmacogenetically. And that's part of CDPF. Everything that I'm discussing here, it's going to be in the book, okay? And so, the approach and the methodology and the thinking and the processing and solving problem and laying down the problems and then analyzing it based on these 4 things: redox, metabolic, immune, regenerative, and then starting, dissecting the information. And I think that's how we redefine medicine, and combining those both mainstream medicine with integrative, and make reason to use pharmacogenetics. Now it's become medical necessity now for pharmacogenetics to be involved here, because we have a crisis of side effects from Ozempic due to the pressure on the pancreas. And also there's other side problems, which is muscle wasting, bone mass decrease, and all that stuff. So we're going to talk about that. And so let's go and find out this pharmacogenetic testing that would help us to tell us, oh, these patients are not qualified to take Ozempic because they may develop diabetes. Then then what I need to do is to figure out something different. There's a lot of other pathways that we can use to decrease weight, not necessarily pressuring in the pancreas to produce insulin or inhibiting glucagon. We can work on other pathways. We can activate the AMPK using metformin. We can also decrease or delay the empty of the stomach using metformin. We can also decrease the appetite using metformin. So we can come up with a capsule with metformin, just 100 milligram. But is that enough? No. We need also decrease the absorption of the sugar from the gut. We can use acarbose, which is an anti-diabetic drug, same like Ozempic. And acarbose, it will inhibit the amylase enzymes in the gut, preventing degradation of the carbohydrates and absorption of the sugar. And what's the problem with that? Then you have the carbohydrates accumulate into the gut, and then the bacteria will ferment it, and you develop into gas and bloating. The patient say, "Oh, I'm feeling bloating with the acarbose." Yeah. Then we need to put in that capsule. Anti-gas, whether activated carbon charcoal, and some of you say, well, that will cause it may cause attaching to the other drugs in the capsule and preventing it from being absorbed. I don't care about acarbose not being absorbed, because acarbose we need to be in the gut. It's not going to be absorbed, and maybe metformin, but even the percentage of that's going to be, let's say, 10%, 20%. But activated charcoal is good for detoxing. So that's one thing you want to consider when you are managing weight loss. But if you don't, a doctor say, no, I think it's better to use other anti-gas. There's many anti-gas that does not cause chelation of those drugs that you're adding together. And I think I have a pharmacist here, Dr. Mike Emmanuel. He's here. I don't know if you're here or not. If you're here, just say, hey, I'm here. And if you're here, just put your information so people, they recognize this capsule. And this capsule will also contain amloxanox, which is very important because it activates AMPK, and also it heals the gut. All the inflammation, all the ulcers in the gut, and the leakage source. It does help. Are you there? Can you hear me, guys? Because I hear silence there. Yes, I don't want you to be I don't want you to be sleeping, guys.
No, I hear you.
Okay, are you enjoying this conversation?
Yes. No, this is very educational.
Okay, so I'm
amloxanox.
Yeah, amloxanox, and I think the one who brought amloxanox to the table, Dr. Joseph James. So I want to appreciate that he brought something that's big. It's just a drug that's being used for mouth ulcer. But we find out amloxanox can have many, many clinical applications, including weight loss, because it activates AMPK. But also we're looking for something that heals the gut ulcers and inflammation that's not clinically, because that can be source of the leaky gut syndrome. And those diverticulitis, inflammation, I think amloxanox will be the best for that. And so amloxanox is there. And then we add naltrexone to inhibit the appetite, and metformin causes malabsorption of vitamin B12, so we add B12 there. B12 does help to speed the process of burning of the fat. That's right, activate the mitochondria, we know that. And so there's also quercetin, ECGC, and all those activates the AMPK, and it helps to burn the fat. And it's a very nice capsule. It's produced in National Pharmacy in California. Hopefully Wilson National Pharmacy will work together, and they also have this capsule. But right now, the only one who has this capsule is National Pharmacy in California. If you're interested, reach out to Dr. Mike Emmanuel. I'm supposing he's still here. But then, I don't know if he's here or not. But if he's here, it's good to just put your name and so people know the source. And then you have Dr. Hotan's, which I helped him to design probiotics, which has the bidiform bacteria, which is very important because they produce those postbiotics, the butyric acids, which helps to decrease inflammation. It's very important to add probiotics in your regimen, especially when you're giving big pharma like metformins and all that, because it may disturb the microbiome. So you have to have this kind of probiotic, postbiotics, prebiotics in one, putting it there along with this capsule just once a day. And that helps to restore any disturbance in the microbiome. But also those bidiform bacteria, also it does help in weight loss because they secrete postbiotics, which is butyric acid, which definitely help to decrease inflammation. And we know that where is the worst fat tissue that you have in our body is the visceral fat. Everybody above 50 years old of age on this whole planet, they have extra visceral fat. And that visceral fat is a source of inflammation, is a source also for storing carcinogenic toxins that's fat soluble, okay? And getting rid from that extra fat, you get rid from even the risk of having cancer. You're getting rid from the storage of those toxins, those petrochemicals toxins, the plastic toxins, all of this fat soluble toxins, where they store in this fat, and they release slowly into your body, and they're carcinogenics, and they contribute in increasing the risk of cancer. We know the risk of cancer during your lifespan is a flip of the coin, 50%, right? Everybody here, you would have cancer, 50% chance of having cancer during your lifespan, okay? When you reach the age of 90, you will have prostate cancer with the rate of 90%, okay? But most of the people, they don't get into that age. So we want to be average here. 50% of all of us during our lifespan, we will have cancer. And we need to look at all the risk factors of cancer. And one of them, the big one of them, is that visceral fat. Get rid from it. In the future, any extra fat will be considered unhealthy. It will be like smoking. And if you see anybody has extra fat, like myself, or gynecomastia like myself, then that's a problem. That needs to be put in the hospital and needs to be taken care of in the future. I'm not talking about now. Now it's normal. In fact, they are creating clothes for that and fashion for that. But fat is it's a source of aging. It's the reason of cancer. It's the reason of speeding the process of the aging and aggravating any underlying condition there. And so we need to change our thinking, and that if you see any patient with extra fat, we need to say this is not good, especially with this environment that we're living. I mean, maybe in the mountains where we don't have all these toxins, I think they can still live and they're okay. But with the environment that we are living right now, it's all petrochemicals and plastic, then we need to consider that extra fat is a hazard or risk of aging and cancer and inflammation, and we need to work on developing protocols. So this capsule, I think I need it for myself as well. It also has DIM. I don't know the pronounce of the DIM. It's just diindole, whatever, methylene, whatever. It's DIM. It's a drug that inhibits the the aromatase enzymes. You know, the aromatase enzymes that convert the testosterone to estrogen. We have two aromatase enzymes. We have one in the gonads. What's the name of
really
it?
quick?
Yeah.
No, the only reason why I got in here is because I thought there was a different mechanism. I thought it was helping to convert estrogen in the liver to a better estrogen, as opposed to, I think, more estrone. You know, I think estrone is the problem of estrogen dominance. So for women who have estrogen dominance from, say, the environmental estrogens or estrogen disruptors, I believe it's helping to convert those estrogens into it's like a hydroxy estrone, but don't quote me on that. It's a
let me go. If there's
form.
aromatase for that, it's going to be different. Okay, and so there's a third aromatase, and that's the aromatase that convert the estrone to estradiol. Okay, that's a different aromatase from the aromatase that convert the testosterone to estrones, which is the fat ones. And I think Dr. William here will be in the same page, hopefully, with me. So there's that third aromatase that you talked about.
You talking to me? Oh, looks like you're froze up.
Lost him.
Well, looks like we lost him.
Can anybody comment on DIM? Because I'm a little bit confused if it's blocking the conversion of testosterone to estrogen versus helping the estrogen to be converted to not to estrone so much, but to a sort of a non-toxic estrogen.
It does both.
It does both.
It does both.
Okay,
He's,
you.
it acts as aromatase, and you're talking about excess production of 4-hydroxy and 16-hydroxy estrone or estradiol. So it favors the
estrone was right.
2-hydroxy path.
And the hydroxy path is the good path.
Yes, the 2-hydroxy.
Yeah, there's the 2, the 4, and the 16 hydroxy, and we used to call it the good, the bad, and the ugly. And like
Nice.
Carol said, that the DIM does that. That's diindole methane, which I think is, Carol, is that converted from IC3 or is it the other way around? IC3 goes to DIM.
Yeah, IC3 goes to DIM.
Okay, that's indole 3 carbonyl. And you can get these products, but it's always better to, as Carol said last time, is to measure and see where you are on these things, because these things, which do lead to cancers and whatnot, if we can, as you said, Dr. Joseph, modify the pathways through supplements and things, boy, that's a win.
To address Dr. Pierce's question a while ago, in terms of assessing inflammatory oxidative markers, so clinically, you can do this with the ADMA testing, SDMA, even F2 isoprostanes, fibrinogen, HSCRP, LPPLA2, myeloperoxidase, and oxidized LDL. So you can get all of this through a cardio IQ of Quest or even Boston Heart.
And then Dr. Nario, doesn't the cardio IQ also give you particle size for the LDL, HDL?
But yeah, so that's called the NMR lipoprofile. So that's
Okay.
the more specific testing for lipids now, rather than doing the cholesterol, the classic cholesterol panel of just HDL, LDL, and total cholesterol. So
Right.
yes, they're all there.
Okay, and I'm wondering if that's in this document that Dr. Halasa is doing, where we talk about maybe updated testing. That's great information to people to know, rather than just the standard tests that are out there.
Oh, yeah, that's probably good for him to answer. So I'm not sure if he included that, but that is currently in Mark Houston's I guess teachings in the A4M modules. He's promoting more of the NMR lipoprofile in terms of now the more accurate way to assess mortality and morbidity in relation to cardiovascular diseases.
Can I ask, would the DDI HUMAP test provide the information that would lead to optimizing the DIM and IC3 supplements?
I think it's probably on there. They're copying Dutch, which has it.
Okay, Carol, do you have a problem with this explanation with DIM?
No,
Dr.
it
Carol?
does. It does both.
Okay, so let me talk about this, because it's very critical.
Thank you.
About the aromatases that of the fat versus aromatase of the gonads. They are different, and so DIM and other drugs that we have that inhibit the aromatase that we're giving, they don't inhibit the aromatase of the gonads. So that's very important, very, very important. Because if I'm giving a drug that inhibits the aromatase of the gonads, then I'm inhibiting the conversion of testosterone to estrogen, especially estradiol for the female. And that's going to be a disaster. No, we're giving those aromatase inhibitor does inhibit the fat aromatase, not the gonadal aromatase. That's very important. Okay, so this concept is critical and important, because when you have too much of fat and you have too much of fat aromatase active because of too much of fat cells or fat the tissue, and you end up converting all those testosterones of the female, that obese female that we talked about, into estrogens. Okay, so what does estrone does? Estrogens will go to the hypothalamus and inhibit the release of the gonadotrophic releasing hormones, which are important to release the luteinizing hormone and follicle stimulating hormones. And if that's the case, then you have less of those hormones. What will happen? You will have less of conversion of testosterones of the gonads into estradiol. So you will have less of estradiol, and you will also have too much of testosterone that's produced by the gonads, which will convert to estrogens, and you have this vicious circle. So what will happen here is that you have too much of estrogens, less of much of estradiol, right? Also because of you know, estrogen is inhibiting the production of enough of estradiol, because it blocks the whole hypothalamus pituitary gonads and interfere with it. Okay, and your body starts shifting into production of estrogens, and what will happen to your progesterone will also decrease in relative to estrogens. And then you will have something that's called estrogen dominance. So you have too much of estrogens, okay, not the healthy estradiol, because that is being compromised by estrogens inhibiting the hypothalamus pituitary gonadal axis, right? And then you have a problem with converting testosterone to estradiol. So you have less of estradiol, too much of testosterone, which converts into the estrogens. And then you will have you shifting the whole thing into production of estrogens. And all the progesterone will be depleted into production of estrogens, which are the bad, well, it's not, if it's extra, it's not good, especially estrogen. Estradiol is better than estrogens because they are partially a stimulator of estrogen receptors. And it interferes the production of estradiol. And estradiol is very important in production of high density lipoprotein, which is very important to clear up the fat or the bad cholesterol in the blood. And that's the reason when I asked Dr. William, he said, well, in men, we have to have enough of estradiol as well. Not estrogens, but estradiol, because estradiol helps to increase the high density lipoprotein. So that's a discussion happened in Vegas when we were eating that big meal. Where is that, Dr. William? He was in the buffet, the castle one, somewhere in Vegas when we met. Are you there, Dr. William?
Yeah, it was Caesar's.
Caesar's, yes. He told me, yeah, you know, but it's still Dr. Halasa, he's cheating me. He's giving me the information. Estradiol is still we need it in men, because I thought testosterone is the only thing you need in men, right? You don't need much of estrogen.
Well,
I don't know why there.
But
he said, no, that's not right, because we need to have high density lipoprotein. Estradiol is very important to produce that. So I'm right now talking about the female fat. I'm not obese female. I'm not talking about the male right now. We'll just focus on this. So you have too much of estrogens. Then you have something called estrogen dominant syndrome. What's that mean? You have too much of estrogens, less of estradiol, less of progesterone, and the ratio between generally estrogen, including estradiol, with progesterone, or the progesterone versus estrogens, progesterone the top, estrone down, and it's going to be less than 100. And when you have it less than 100, then you have something called estrogen dominant syndrome. It means that you have less of progesterone, too much of estrogens. When you have too much of estrogens, what estrogen does versus progesterone? Why you have to have a balance there? Okay, why we have the balance? Is estrogen good for women? Yes, they are. But in order to be estrogen good for women, you have to have enough of progesterone. Why is that? Why we said estrogen is good all the time, and it helps for the women to protect them against hypertension and metabolic syndrome. Why estrogen suddenly become bad? I think that's the question everybody's asking. Well, is because when you have too much of estrogens, especially the estrogens, and you have less of progesterone, estrogen, what it does, it stimulates the proliferation. Yes, it stimulates the proliferations of the cells. So it's good for rejuvenations. But if you have too much of estrogens, you have too much of proliferation, and you don't have differentiation from the progesterone arms, then you're pushing your cells to divide fast. Yes, you rejuvenate, that's good, but they are immature. And if they're immature, they don't produce enough of they're going to have a time to produce enough of antioxidant machines, right? And if they don't have antioxidant machines, then those cells, they have high redox potential. They have high amount of free radicals. And in that case, you're kind of inducing oxidative stress. So that's the reason. So what you need to have differentiation proliferation. You need maturation. You need to give that time for the cells to produce enough of antioxidant machines, so you don't have a cell that has too much of free radicals and producing too much of free radicals. So a patient, an obese patient, having too much of estrogen, their cells are producing too much of free radicals because they are proliferating without differentiating. They don't have a time for the antioxidant machines to be produced, generated enough. They don't have that time because of the ratio between estrogen and progesterone. Progesterone helps to mature those cells. Is that what happened in the endometrium? Estrogen proliferate, progesterone differentiate. But it's not just an endometrium. It actually in whole our body. And that's the reason we need to have sex hormones replacement therapy to slow the process of aging of females, because what keeps them from aging is that balanced estrogen progesterone, because we consider them as rejuvenating hormones. They are the one who stimulate the whole body to proliferate and differentiate. So if you have deficiency of sex hormones in the female, then what will happen? You have a problem, imbalance of one of the pillars of chronic disease prevention and management we talked about, which is the regenerative status is being compromised because of the sex hormones. So if you see here, I'm fixing the metabolic, but at the same time, this will lead to fixing the regenerative status. You see those 4 parameters that we are using to measure or manage the chronic diseases, they all interface and work together, and they cross. It's like they overlap each other. So that's very important concept. And then, yes, you have to have enough of estradiol, and too much of estrogens, which will compromise the hypothalamus pituitary gonadal axis, which leads to decrease the production of the estradiol from testosterone, because this would eventually inhibit the conversion of testosterone to estradiol at the gonadal level. And that's a problem with the females. That's why the obese female, they may have some of them, they have extra, some growing a hair in their face, and what we call virtualization, and this can also push things into polycystic ovarian syndrome. If they have genetic background, then that ovary, that they can become polycystic ovarian as well. And so this is the important part that we need to know about estrogen dominant syndrome. So here, if you do have too much of estrone, if you have estrogen dominance, right, then the fat cells will become resistant to shrink. The fatty acid oxidation will be compromised because of the free radicals and oxidative stress that is generated by the estrogens stressing those fat cells, because it's not being balanced with progesterone, and they become insensitive, and they don't shrink. And so it's very critical in managing weight loss is to consider estrogen dominant and work on it as well by giving patients aromatase inhibitors. We're talking about fat aromatase inhibitors versus the gonadal, because the fat aromatase inhibitors, they don't inhibit the gonadal ones. We need that to be intact. And that's the reason we give them calcium glucourate, we give them DIM. Dr. William is giving the other drug, which is the big pharma one. What's the name of it that they say to you that makes bone mass? Anastrozole, right? Anastrozole. Yeah, but if you do high dose versus low dose, it's going to be different. And if you use it in a reasonable amount, but we can start with natural aromatase inhibitors, and if it does not work, then we may end up doing the big pharma one, as they're more potent. But we try first with the supplement. So that's the reason we add them in the capsule that we talked about, and that's the reason we're going to develop capsules, supplement part of aromatase inhibitor included. So you have to have supplement and a big pharma products either together in one capsule by the compounding pharmacy, or we can develop a supplements which has all those ideas and all those concepts in it, ECGC, quercetin, aromatase inhibitors, and all that, and the probiotics, the postbiotic, and all that. We can put it with Dr. Hotan. The Dr. Hotan ones has only the pediform bacteria. But Mike Emanuel, the compounding pharmacy, I think he put everything there, but still you need to have some probiotics to have a complete management there. So that is estrogen dominant syndrome, metabolic syndrome, obesity. I mean, I'm trying just to be kind of summarizing it in a way it makes sense, and hopefully that we're going to get a lot of questions. Finally, our last thing, I'm going to talk here, and then I would like to open a discussion here in managing any chronic diseases. And I'm going to give you an example here in the chapter in the book. For example, let's say if I want to manage Parkinson disease, right? And this is the chapter is talking about Parkinson disease here. Okay. Let's see, and managing Parkinson disease. The immune system, okay. Okay, so this is, let's go all the way down. But anyway, what I'm trying to say is that when we manage any chronic diseases, let's say in case of Parkinson is a disease where you have dopaminergic neurons. They are being degenerated. And the reason they've been degenerated because they have a problem of recycling their byproducts, which is the quinins. So they don't have much of genetically. The antioxidant machines are being shut down, or it's not working well. So they don't clean. They're unable to clean the quinins, the byproducts, the waste of L-dopa. And then the quinins will stimulate apoptosis and degeneration of those dopaminergic neurons. And the patient will end up manifesting Parkinson's disease after 80% of the dopaminergic neurons are being not working and function. And then 20% are being pushed to function, to put the brake on the body to prevent it from tremor, and also inhibiting the antagonist, because and you know how when you're moving your body parts, you have a paddle and you have a brakes. Paddle is your acetylcholine, and the brakes is dopamine. And if you have less of dopamine because of the brake oil pipes is being broken and leaking, that's what's happening in dopamine. They don't have much of dopamine there. Then they don't have enough to brake. Then patients will have this rigidity and problem of relaxing the antagonist when they're trying to contract their muscle and move the agonist to produce that wanted motion. And then they have rigidity and all that shaking and shuffling and masked face and all the symptoms of Parkinson's disease and your frozen body. And the reason because, they have problem inhibiting the antagonist, and the whole body is kind of all contracted because of, acetylcholine is stimulating the whole muscles, antagonist and agonist at the same time. So we need that break. We need to stop the antagonist for the agonist to contract to move your body part. And so let's say 80% are non-function, and then 20% are functioning, but they are not producing enough of breaks and manifest the patients. They come up with Parkinson's disease. And the neurologist will say, oh, you know what? Nah, we cannot stop this from progressing, but we can slow and give you some L-dopa, give you some fuel there, or some oil brake to put some brakes, whatever. But what happens when you give L-dopa? You're pressing those 20% of dopaminergic neurons to produce the brake, and you're pressing them. Giving them L-dopa, and they're converting it to dopamine, and then dopamine turns into quinins, and then those neurons, they don't know how to recycle this waste. It's like a house where you're filling up your refrigerator with food, but you're not taking your waste. What will happen? The cells will accumulate with waste with the trash, and that will toxicate, and fungus will develop, and then that will kill the people inside that house. It's the same thing with those dopaminergic, what's being left. You're filling up the refrigerator with L-dopa, but you're not taking the waste, which is the quinins. And what happened is that this will speed up the process of degenerations. And so they need L-dopa more, and to the point L-dopa is not working, and they say, okay, well, here there's no much left of dopaminergic. Let's go ahead and inhibit the cholinergic neurons by giving anticholinergics, right? And possibly you can give them also Benadryl, because Benadryl is anticholinergic drug. But they start giving those anti-cholinergic drugs to stop the gas, the rigidity, and so that's what the mainstream medicine. That's the protocols of the mainstream medicine. Integrative doctors, they say, well, let's think a little bit. Why it's degenerating, first of all, and then is 80% of those neurons that the neurologists, they are considered them dead. and that's it. The neurons are permanent neurons, and they die, and we cannot revive them, which is true. But they just give that impression, the neurologists give that impression, those 80% are dead, don't talk to me about it. Talk to about 20% that's being left. Well, regenerative doctors say, well, maybe those 80% are not dead. Maybe 50% are stunned by inflammation, and 50% are dead. Yes, we and the mainstream medicine neurologists, we agree that the dead neurons will not be reversed significantly with all the protocols, with all the stem cell therapy. Well, let's forget about that. But let's think about those 50% of those 80% that you thought they are dead. I think they are being inflamed and stunned, and that's why they're not functioning. So let's go ahead and recover those neurons and give them and restore the redox. And restoring redox is not just by giving them antioxidant, but also stimulating the expression of antioxidant enzymes. And not just that, and looking and screening all the free radical generators. So it could be a patient has underlying fungus infection, could be bacteria infection, could be leaky gut, could be taking drugs that produce or induce oxidative stress, could be deficiency of 6 hormones, could be you can wrap with all of this, right? And come up with a wrap. And you can wrap with all the screenings of the free radical generators, right? And then you screen them all and you optimize the health, and you can see the patients is doing good. And he's not shaking. I mean, I have witness, and some of them maybe are here. I cannot even understand what they're saying in 2 years ago because of the slurred speech of the Parkinson. And now he's speaking completely like big sentences, big words. I can hear him, I can understand him. And so how he has this Parkinson, and now he's talking, and I can communicate with him, and I can hear him, I can understand him. 2 years ago, he can't, because he is helping himself by giving to himself everything that takes to slow the process of degenerations, which is screening the redox and looking for all the deficiency and optimizing his health for that, and then looking for any metabolic deficiency, vitamin D, whatever, A, whatever, looking for that, and then also possibly balancing his immune system by giving low-dose naltrexone. He's giving everything, right? By giving a losartan, possibly inhibiting, there's drugs that inhibit or stimulate the antioxidant arm of renin-angiotensin system. And so is working toward this idea of restoring the metabolic, immune, redox, and regenerative. And he was able to completely slow the process of degeneration and waking up and reverse those stunned neurons, those inflamed, and make them function and produce dopamine. And so that is a difference between us as CDP and physician versus neurologist. And that's what we're trying to come up with, the structure and the protocol and mechanism of action, how things works, like how light therapy works, how ozone works, how the oxygen chamber works. All of them works on restoring the redox balance. And we have a chapter in the book showing all the mechanism of all this energy form of treatment that's in A4M, those light, those sound, there's all this energy works because your body can absorb those energy and transform them into redox signaling and optimize the redox balance. And that's the reason patients are benefit from light therapy, from electromagnetic waves, from all that. But without understanding of redox medicine, those companies, they have a hard time to communicate with doctors, because doctors want to know the mechanism of action, how light therapy works, how electromagnetic therapy works, how hydrogen therapy works, how ozone works, how prototherapy works. Acupuncture, how acupuncture works. It works through redox. And we have a complete chapter of redox medicine in the book. So that shows the whole mechanism of action. That will reason why we're doing it. And then when you add antioxidant and we add the things that we're doing, it's all synergistically working together into reaching to the goal that we want, which is the key process of the physiology or pathophysiology, restoring them, which is the 4 pillars that we talked about: redox, immune, regenerative, and metabolic. So now we know Parkinson's disease is not just giving them L-DOPA, but also slow the process of the degeneration of those 50% of 80% we thought they are dead. They are inflamed and stunned. And we give them glutathiones, but don't do too much of glutathione, because then you end up with glutamate or toxicity, and glutamate stimulate oxidative stress, open up calcium channel, and release the free radicals from the mitochondria. That's not what you want. So if you do glutathione, make sure you're adding NAC and possibly glycine to recycle the glutamate back into glutathione. And also you give them all the polyphenols. You can give them light therapy, electromagnetic therapies. You can give them, renin-angiotensin, like losartan, and drugs that helps to stimulate the antioxidant arm of renin-angiotensin. You give them metabolic therapy, decreasing the inflammation through metabolic, which is activation of AMPK, clearing down the inflammasomes, senescent cells, cancer cells, all that. When we talked about AMPK, if you stimulate that, that does have anti-inflammatory effect because it gets rid from inflammasomes and many other things. It empower the antioxidant enzyme expression, and that will help to neutralize all those free radicals. So you give them all this therapy of metabolic redox, and you see balanced immune system, give them peptides like thymosin beta, BP157, what we call it, you give them low-dose naltrexone. You can give them metlum. Metlum is very effective, especially with inhibiting TH17 and buffering the redox. That's very, very effective drug in that. And you start balancing all of that, right? Eventually, you can Salaheldin, Dr. Joseph likes Salaheldin. It does help increase the dopamine, but there's some side effects. Some people experience it, which is that because it's not centralized, it may affect the peripheral autonomic nervous system. So some people, they may have high blood pressure. That's the reason it's good to do nanoparticle, the platelets nanoparticle, possibly that helps to target and deliver the drugs into the pathology versus the physiology. So that's another part of the in the book. It emphasizes, and that's an itch book, an itch system. It emphasizes on using nanotechnology, which is platelets-derived nanoparticles, to deliver the injectables into. Can you hear me, guys?
Yeah, can I comment on the Salaheldin?
Yeah, go ahead.
Just quick question. So you said you had mentioned something, and just so I heard you correctly.
Yeah, so I reached out to somebody about Salaheldin, and he said, we know this drug works, but it may have some peripheral effect. And she said, I have experience of high blood pressure from it because it does increase the sympathetic activities peripherally, in addition to increase the dopamine in the brain.
But I'm curious what the mechanism would be because
it does increase it inhibits the reuptake of dopamine and norepinephrine and serotonin.
It's a selective MAOB inhibitor. So based on, there was a book on it that I reviewed. There was as many studies as I could find. And the understanding is that at the dose that we give it, it's selective, and that it's just affecting the dopamine, and that all the cardiovascular effects are positive because apparently there's a role for the MAOB inhibition as well, and reducing the redox. Okay, that's the benefit of it, that it's increasing dopamine while buffering the redox because it's limiting the all the breakdown products of dopamine, which are free radical generators. I mean, maybe there was that one patient, but in general, it was my understanding that this was, special because it was the only one really out there that could prevent those kind of side effects. That's always the problem with the non-selective MAO inhibitors or the MAOA inhibitors.
Right. So I think this patient, maybe he used high dose, possibly. Maybe he's sensitive to that drug, and because as I said, it's all individualized based on the epigenetics. Some people respond, a few people they don't respond, and then that will smear the whole thing. That's true, but also the dosage and all that needs to be individualized in a way that it will work for everybody. So it's all about dosage too. It needs to be adjusted based on
and
feedback.
That's true. That's true. My understanding is that the higher doses, with too high a dose, it can affect the MAOA enzyme, which would lead to increase in norepinephrine. But at the lower doses, that's just been shown over and over to be protective.
Right.
And
well,
the
particular this patient, I talked to him about it, and he said, I did receive it before, it caused my blood pressure to go high. So that's why I discontinue. It seems like, first of all, it's personalized thing. And the second part, maybe use the high dose. Maybe he relies everything on it, but definitely the way that we develop the protocols has to be combined multi-therapeutic approach. So you don't need to have a high dose of each of those drugs and deal with the side effects. I understand you, Dr. Joseph. I think that's possibly the reason. So, but in this book, we just want to make sure that we emphasize on the target delivery of platelets, nanoparticle, delivering the drugs into pathology. And we provide a training for that. We teach the doctors how to get all your injectables into platelets, nanoparticles, and delivered into the pathology. It's a very important concept, especially a very important emerging technology that's very important for managing many chronic diseases, especially for condition of osteoarthritis, or you're trying to deliver the drugs into cancer cells or inflamed cells. Using platelets nanoparticle, it's the optimum. And the reason for many reasons. One, first of all, it helps to target the pathology. Second, it changes the pharmacokinetics of the drug where it has a longer effect. Third, it definitely, the efficacy, it's going to be high. And if you are managing bacteria and you have resistance and you put nanoparticle, possibly it will break the resistance. So it's good for breaking the resistance. If you have antibiotic that's resistant to it and you put a nanoparticle, it may break that resistance. And so it also minimizes side effects of the drug, because if that drug is free floating inside the body, it may cause damage to the healthy tissue. But if you wrap it into a package, then you spare those healthy tissue from that drug and you're getting it to the pathology where you need to be. So this minimizes side effects. And that's the reason everybody here in the book will emphasize in its system about this technology. And then if you use light therapy along with photodynamic therapy, that's another technology. It's called platelet-derived platelet nanoparticle loaded drugs, photodynamic therapy activated with light. Then if you have infection or you have inflammation and you want to get rid from the inflammasomes, and you shine the light, and that will generate free radicals, and that will induce apoptosis for the inflammasomes, or apoptosis in the cancer, or apoptosis or killing the infection. That's called photodynamic therapy. But it will be good if we deliver those photosensitizers and those immunotherapy drugs, or those regenerative drugs, or antioxidant drugs, whatever you're doing, you can target to the pathology using platelets nanoparticle. Again, regenerative process, after you restore the metabolic and the immune and redox for the patient with Parkinson's disease with using all this therapy we talked about, then you say, okay, I'm going to do more. I'm going to do exosomes. I'm going to go do oxytocin, right? Oxytocin help to reset the metabolic, immune, redox, and regenerative status. So think about that. And you can do it with intranasal, or you can do it sublingual oxytocin. I like intranasal. Or Dr. Joseph has very good experience with injectable. When I met him in A4M in his room, I could see all of the syringe of insulin there. And if somebody from outside and he looks all the syringe in his table, he thinks, oh, this guy's taking drugs. But the reality is that he's taking oxytocin and he's injecting it into his in his abdomen, 2 international units. Again, if somebody from outside and see his room and there's needles there and there's a bottle of thing inside that, and you can see him, he's taking it, putting 2, I think, what's going on, Dr. Joseph? Are you taking drugs or what?
Well, exactly. But oxytocin, it's a good injectable. It really is. And I think it's it assures that the oxytocin, you get enough systemically if you're doing the intranasal part, which is focused on getting it into the brain, right? So, and I know that Dr. Emmanuel, he may actually will fill those bottles then for patients. I mean, I had gotten it through, through another source, but that's something I think we can consider. I mean, I'm curious what your opinion is.
What is that? Can you repeat the question?
Yeah, I'm curious what your opinion is, using a combination of the oxytocin nasal spray along with the injectable.
Yeah, I think it's cool enough. If you, I mean, you're using the lowest dose, 2 international unit, possibly 12, 25 international unit in the intranasal. So all this are safe dosage, less than what the women will take when she deliver a baby, which is 50 international unit IV shot. So I think it's
And then-
safe for
And
little
then,
dose.
yeah, and the attraction is especially is for aging skin. Okay, that's a big one. I mean, it's the biggest regenerator of the skin, as far as I understand. And then it's also muscle regeneration. It's reducing osteopenia, osteoporosis. It's also cardioprotective. It's helping with buffering the redox with the endothelium, and it's helping with gut motility. And so, I mean, it's really from your lecture that I was able to sort of tie things together. But for the more extreme cases, combining the two really makes sense, especially when it comes to restoring the metabolic homeostasis.
Right. No, you're right.
Right.
You know, again, oxytocin is the drug that will restore it's like when you computer crash and you do reset factory, oxytocin is that reset factory button. And so I like the oxytocin a lot, along with methylene blue and amloxanox and things that we are entertaining here. But oxytocin has a special position, especially after doing all that. So I just want to make sure that everybody will go to National Pharmacy, get that weight loss capsule.
What
I
condition
myself-
do you use, Dr. Halasa? What condition do you use injectable oxytocin for?
I will use it for everything, anything. After I did everything and still the
So-
patient problem, you can use it for, it's like resetting the whole thing. And 2 international unit, subcutaneous every day or every other day.
How many units?
2 international units, subcutaneous. It's good if you inject it into around the abdomen, so you can get the visceral fat possibly taken care of, because you need to restore the balance of redox there, and even helps in 6 hormone balancing as well.
You know, there was actually.
No, but I think in a COVID, when there is a long haul COVID and there is a spike protein syndrome, so you think that how would it interact at that they are still suffering, still having problems. Can you explain how the injection would help?
Well, post-COVID-19, as we talked about, you have TH17 is hyper active and TH2 is hyperactive. And you need to find a way to inhibit the TH17 and TH2. And using oxytocin, it does help to balance the immune system, inhibit the TH17 and TH2. And using oxytocin helps to balance a lot of metabolism in your body, including the sugar and the lipid and all that. And
you had mentioned in your lecture that it's modulating the NOx enzyme, and that's why it's actually leading to modulating TH17 because that's the same pathway.
NOx enzyme is
COVID is triggering.
NOx enzyme is one piece of the puzzle, because the AMPK is the big master there, and down signal of AMPK is increasing the expression of antioxidant epigenetically and inhibiting the TH17 from the beginning, from the get-go. So there is many level of restoration of the redox and metabolism.
I was gonna say really quick, it really hit me when I was talking to a patient who had literally all of her complaints were metabolic related. I mean, as the bigger focus, obviously, that leads to balancing out the immune and the redox. But everything she had was from heart palpitations. She had some heart disease. She had a hemoglobin A1C that was suboptimal. She had increased cortisol levels. She had, I believe she was slightly hyper, I forget if she maybe slightly hyperthyroid. She was dealing with all kinds of anxiety and distress, and of course she had psychosomatic going on as well. But when I thought about everything that she had abnormal, it stuck out as metabolic. And when you think of oxytocin being the master regulator of metabolic homeostasis, and this was a patient that needed something simple, something that kind of covered the territory because of her budget. And I thought, wow, well, oxytocin would really cover so many things. It's a great place to start.
Right. Yes.
And what did you see in that patient?
What did I see in that patient?
Response.
Well, we'll find out. But this was recently that it just dawned on me that everything, all of the markers, all of the things that were abnormal were all metabolic related. Like all of the metabolic was abnormal. And so when I thought about, well, where do you start? What do you do? Do you focus on that, focus on this? Especially in somebody with limited resources, I thought, well, let's start with oxytocin.
But if they have a lot of inflammation, you could have you also given KPV too, right?
Yeah, but KPV is kind of more focused on gut repair. I'm just saying, just from an ideological standpoint, this was a family friend, you know, so that this wasn't, you know, a patient in the office, but this was somebody who, like I said, it made oxytocin. When I was thinking about what would be the most convenient thing that would address like all of the issues that seem to be standing out, of all of the choices that we have, all of the tools in our toolbox, I realized that oxytocin covered it all in this particular patient. I mean, you said it yourself. It's buffering the thyroid hormones, right? It's buffering the cortisol, right? It's leading to increased sensitivity of the insulin receptors. It's stimulating the AMPK. She had metabolic syndrome as well that needed to be addressed.
But through what mechanism does it work on AMPK?
I think I have a big lecture, Dr. Patel, about oxytocin recorded.
Yeah, you did have it, but I'm just you know.
Yeah, it does activate.
Everybody was not there when you. Most of the
Well,
attendees were not there.
What I know, I understand the other mechanisms better. With oxytocin, it's always been a little bit confusing because there's an oxytocin receptor. And what I do understand is the part that is modulating the redox and leading to immune regulation is through the NOx enzyme. There's a pathway sort of indirectly from there that I did have some challenge with understanding it because
no, the NOx enzyme is one of the downstream signal. There is above that, they are remember the one that amloxanox work on, the pro-oxidant enzymes.
Oh, you're talking about
the K beta.
IKK.
Yeah, the IKK and all that.
Okay,
yeah,
through. So there's a similar modulating directly.
They inhibit the pro-oxidant and stimulate the antioxidant expression, oxytocin. That one, but at epigenetic level, at that level, and also it does inhibit the polarization of the immune system to Th17 and helps to balance the whole thing. I would put it another oxytocin lecture again.
That makes sense though. Actually, no, I remember that from the lecture. It's right. Modulating IKK, and that leads to modulating of, I think it's protein kinase A, which is connected to AMPK. That's right.
We're going to have a lecture of oxytocin, maybe not this Monday. This Monday, I'm going to talk about the book again, go more about it, and then get the questions from the doctors, and then get their feedbacks and how we can make this book better. But then after that, me and Dr. Joseph and Pit Patel, we come up with whatever lecture that we need to be done for the other Mondays, because I have 2 Mondays off. But the next Monday, we're going to regain back to 2024. Meanwhile,
Dr. Halasa, do you think maybe we should do this this particular lecture tonight, maybe in 2 parts? I don't know if it's getting
or
no, just the overall book, because I don't know if this, with the Tuesday group typically doesn't go as long as the Monday group sometimes.
Right, it's too long. Yeah.
Mm-hmm. Yeah, we're losing.
Okay, so any questions? Well, we dropped from 37 to 25.
Right.
10 people, you know.
Mm-hmm.
Or
33%, depending on how you want to look at it.
30. We dropped 10 people, right?
Yeah.
It was 37, the max.
Yeah. Anyway.
And now we are 225.
Okay.
Okay. So any questions?
Any questions? Any comments? John, you got anything for us?
Thanks for a good info show. Thank you, Dr.
Yeah.
Halasa.
Okay, next week we have Stefan Hartman's going to regale us with the joys of iodine. And on our group, I'm pretty sure next week we will be joining the A4M network, and so our link will be different. So pay attention to that, okay? I could have done it this week, but we got tied up with the holiday business. But next week, I'm 99% certain we'll be part of the A4M group, so we'll be joining them. So hopefully we'll have a much bigger audience also.
I
Okay,
didn't hear anything from you about the lecture, Dr. William. Do you have any critic there?
do I have any? I got lots of critics, but
Okay, so just go ahead and lay them down.
no. Me? You want me to criticize? No, I have nothing. No, I'm just
Negative or
a student.
positive?
I'm just drinking it all
No.
in.
That's the whole purpose of this lecture and purpose of being here is for us to be critic, whether it's positive or negative, to verify the information. So I like that critics because that's how we learn. That's how we evolve. I'm not the person who is getting offended. Oh, putting me down with his negative critic. No, in fact, that will bring us up because then we can correct ourselves and know what's right and what's wrong. Versus, just saying, oh, you're good, and you want to hear the things that you want to hear. I mean, telling you the things that you want to hear.
There's a question here about an alternative delivery system for aromatase inhibitors besides capsules. So I don't know if the Mike from the pharmacy is still on, or anybody else.
Yeah, I'm here. I'm here. Hi.
So that was the question. Did you hear that?
What's the question?
Question was, is there an alternative delivery system for aromatase inhibitors beyond capsules? So
maybe we can do a nasal spray. We have to check.
Yeah.
Nasal spray, maybe.
Okay. So I don't have one off the top of my head.
I'm gonna check it out.
Okay.
Dr. Carol, I forgot to mention progesterone. That's what your forte. And yes, progesterone is very important. As we mentioned, progesterone is being drained into estrogens, and you have low progesterone. And progesterone is not just to replenish the sex hormones and estradiol, but also it helps to inhibit the aromatase of the fat as well. So it's aromatase inhibitor. I just want to add something to Carol Peterson there, not to make sure that we're lining up with the importance of progesterone. Right. I don't know if she's here. Are you there, Dr. Carol Peterson?
Yeah, she's still on. She's on the list.
Yeah.
So
she's still, but she's sleeping. I think I did not mention progesterone. She got a bit upset.
She went to get.
I am for progesterone in the estrogen dominant for sure, 100%. I want to make sure that because that's what she's promoting, and I think it's correct. And yes. Any other questions? Are you happy, everybody? That's the questions I give to the kids. Are you happy, Dr. William?
I'm thrilled beyond belief.
That's all we need is to happiness.
Thank you so much for your time.
Be happy, be healthy, right?
Yeah. Check your email to see if you got the thing I sent you this morning. Okay.
Okay, I'll go through it, but still, I'm going to send you the whole book.
Well, I just want you to see if that's if I'm on the right track here.
Yeah, you are. Come on, man. We're learning from you, man. We need all of that.
So
no, it's a good one. No, we need everything. I will send you the book, and you can punch whatever you want, and we're going to perfect it, optimize it, and then we're going to put it in the market, possibly redefining the medicine. I'm just laying down the foundation for you to punch your thoughts and directions.
Okay, great.
Is that good?
Yep, that's good. Okay. Everything good, John?
Wonderful. Thank you very much.
You got through New Year's Eve without getting arrested?
Yeah.
That's good. Okay. 2 years in a row. That's a new record, huh?
Oh.
Okay. Say hello to Sylvia for me. Okay, everybody, just pay attention. Next week, we'll probably have a different link and a different look. So thanks for everything, and we'll see you again next time.
All right. Good night, everybody.
Good night.
Good night.
Hi, everybody. Great class.